Today we're going to talk about increased alveolar volume and lung diffusion capacity in former preterm infants randomized to 2 extra weeks of continuous positive airway pressure in the NICU. And of course, this was a study done here at OHSU with all of the tremendous support of our caretakers. So altered lung development can be seen with all preterm infants, even those without initial clinical lung disease. And we know that preterm infants are at increased risk for wheezing, for asthma, and respiratory hospitalizations as they age compared to infants born at term. We also know that an individual tends to follow along a pulmonary function percentile that's established very early in life. So if preterm infants start with an altered or diminished lung function, they may have limited lung function throughout their life, as shown in this figure of pulmonary function trajectories. So in this figure, the blue line represents healthy term children where there's a continuous growth of the lungs and thorax throughout childhood, resulting in a maximum lung function at around 22 years of age. And then there's a gradual age-related decline. But because of considerable reserve, most individuals will not develop lung disease. However, if we look at the early part of the curve and look at the red line where we practice our medicine, if a child is born with suboptimal lung function due to prematurity, their lung function may remain diminished throughout childhood, may not reach their optimal lung function as a young adult, and may be much more predisposed for respiratory disease as they age. So to attempt to optimize early lung function and avoid iatrogenic damage in preterm infants, the early use of CPAP has really been very well studied as the standard of care for the acute management of infants with respiratory distress, and as we all know, provides a number of physiologic benefits to the preterm lung. However, there is no consensus regarding the optimal duration of CPAP in stable preterm infants, and there is preclinical and clinical data to show that mechanical stretch such as that from CPAP, may benefit lung development. So taking a step back, is discontinuation of CPAP a success, or is there another way we should be thinking about CPAP application? In general, there is evidence that application of chronic mechanical strain to the lungs can result in changes in lung volume. And this is a figure from a study in tracheostomized ferrets who were placed on CPAP at 6 centimeters of water or control for 2 weeks and were allowed to move around in their cages during this time. And total lung capacity, as shown on the y-axis, was measured at baseline and for 2 weeks thereafter. And you can see that at the beginning, the total lung capacity between the two groups was exactly the same. But at the 1 week measurement, the total lung capacity in the ferrets who had been on CPAP was increased. And at week 2, this increase was even significantly more. And the interesting thing is that during this study, they also measured lung weight and total lung protein and DNA, which were significantly increased in the CPAP treated ferrets, but the actual lung recoil was the same between the groups. And this seemed to indicate that the CPAP and the strain from the CPAP was actually associated with acceleration in the lung growth and not just simply over lung distension, but actually likely remodeling of the lung parenchyma. So here at OHSU, we recently published a pilot randomized controlled trial in which we randomized preterm infants who were born at less than or equal to 32 weeks and then who met specific respiratory stability criteria on CPAP to either CPAP discontinuation to room air, which is our standard here at OHSU, or to 2 additional weeks of CPAP. And we performed measurements of functional residual capacity or lung volume as shown on the y-axis here at randomization, as well as at the 2 week time point when the infants have been randomized to either 2 extra weeks of CPAP as shown by the blue line or to off CPAP as shown by the red line. And then all of the patients were taken off of CPAP at the end of the 2 weeks. And then we also measured FRC right before discharge. And so the solid lines show the treatment period. The dashed lines show the interval from the end of the treatment period to discharge. So as shown in this figure, those infants who were randomized to the 2 extra weeks of CPAP had significantly increased measurements of FRC at the end of the 2-week period, and we were excited to see that these changes persisted at discharge also. And although this initial study was very exciting, we were unable to continue to study the infants with pulmonary function tests after discharge to evaluate the potential duration of the effect of CPAP on lung growth and function. So we were lucky enough to obtain a grant from the NHLBI to accomplish the following aims in a new cohort of randomized infants. Our aims were to evaluate whether 2 additional weeks of bubble CPAP for stable preterm infants increases alveolar volume at 6 months of corrected age compared to infants who have their CPAP discontinued per usual care in the NICU. And one of our secondary outcomes was to evaluate whether the 2 additional weeks of bubble CPAP increased lung diffusion capacity at 6 months of corrected age. And we also looked at whether the extra 2 weeks of CPAP in the NICU increased forced expiratory flows in randomized infants, again, at 6 months of age. This slide gives an overview of the study. So focusing here on the right, it was a randomized single-blind study with the individuals collecting outpatient data after discharge and the statisticians blinded to NICU treatment. The inclusion criteria included infants 24 to less than or equal to 32 weeks of gestation at birth, who required at least 24 hours of bubble CPAP delivered via Hudson prongs for clinical care. Multiple gestations over twins were excluded. The infants qualified for randomization once the respiratory stability criteria were achieved, and those are listed here on the left, and basically included being on a CPAP of 5 in room air, respiratory rate less than 60 breaths per minute without retractions, less than 3 episodes of self-resolving apnea, bradycardia, or desaturations, in 1 hour, in any 1 hour for the previous 6, having a saturation over 86% for 90% of the time over the past 24 hours, not currently being treated for PDA or sepsis at the time of randomization, and tolerating brief periods of time off CPAP for CPAP cares. So once these respiratory stability criteria were met and consent was obtained, a baseline FRC was measured, and then the infants were randomized to either 2 weeks of CPAP or to CPAP discontinuation to room air, which is the standard at OHSU. During the 2 weeks of treatment, the subjects were monitored for treatment adherence to their assigned arms. Also, we watched for any serious adverse events or any adverse events. And then the FRC was measured at the end of the 2 weeks of treatment, and the infants were brought back at 6 months of age for the performance of the primary outcome of alveolar volume as well as lung diffusion capacity and forced expiratory flows. And also after discharge, we called the parents monthly to gather respiratory histories. So this is a picture of our infant respiratory physiology lab at Oregon Health and Science University. At the 6-month PFT, we measured alveolar volume and lung diffusion capacity with the single breath technique with an induced respiratory pause with a standard test gas. And this was done in collaboration with my co-PI, Dr. Tepper at Indianapolis University. Chloral hydrate was used for the sedation. We followed American Thoracic Society and European Respiratory Society criteria for the performance and acceptance of the testing. Our primary analysis was by intention to treat. And also at the study, we performed measurements of forced expiratory flows by the raised volume rapid thoracic compression technique. And here's one of our therapists, Diane, performing testing simulation on a little teddy bear. So this figure shows our trial profile. We screened 276 infants to consent 108, and we enrolled and randomized 100 infants, with 46 being assigned to the discontinue arm and 54 infants being assigned to the extended CPAP arm, so to the 2 extra weeks of CPAP. And I should mention that if both twins of a twin pair met qualification to be randomized, the first twin was randomized, and then the second twin was assigned. So there tended to be more twin pairs in the extended group, which is why the number is slightly higher in the extended group. We were able to complete 46 measurements of FRC in the discontinued group and 52 measurements of FRC in the extended group. And then at our 6-month test, we achieved 46 successful measurements of alveolar volume in the discontinued group and 47 measurements in the extended group. And these numbers met our predefined sample size of 34 per group to achieve a 12% difference in alveolar volume. In terms of maternal and delivery characteristics, the groups were very comparable in terms of maternal age, as well as race, about 80% white. Also, education were very similar. Maternal diagnoses that may affect lung development, such as history of asthma, preeclampsia, also antenatal steroid exposure, and mode of delivery. Both groups were 30.2 weeks at delivery, and about 27% were born at less than 29 weeks of gestation, which was one of our stratification variables. This slide shows the infant demographics at birth and also at lung function testing, or FRC testing, in the NICU. Both groups of infants had very comparable birth weights at about 1430 grams. The discontinued group tended to have more females at 52% versus 35%. Importantly, the post-menstrual age at time of randomization, so when they met the stability criteria, was 32.4 weeks in both groups. Both had very comparable weights at randomization at about 1580 grams, and their lengths were very comparable, which is an important variable in terms of pulmonary function testing. This figure shows the FRC measurements in the two groups at baseline and then at the end of the 2 weeks of treatment, with the green line denoting the infants randomized to the extended CPAP, and the pink those randomized to discontinue CPAP. The FRC measurements are shown on the y-axis. So at baseline, the two groups had comparable FRC measurements, but at the end of the 2-week treatment period, those infants randomized to the extended CPAP had a significantly higher FRC measurement with the P less than 0.05, and these changes were similar to what we had seen in our initial pilot study. So 93 of an available 98 infants had successful outpatient tests at 6 months of age, and this was a 95% successful completion rate, which we were very happy with. There was no significant difference in the birth weight, race, or sex between the groups who had successful outpatient testing, as shown here. Again, there tended to be more females in the discontinued group. The extended group had more twin pairs at 30% twin pairs versus 13%. The age at outpatient testing was about 7 months in both groups, and there was no significant difference in the weight or the length at testing at outpatient. So as they say, this is the money slide. This figure shows the lung function results at 6 months of age, and in this figure, the pink bars show the infants who have been randomized to discontinue CPAP in the NICU, and the green bars are the infants who had received the 2 extra weeks of CPAP in the NICU. So here we see alveolar volume, which was significantly increased in the infants who had received the extra 2 weeks of CPAP in the nursery. And again, this is testing at 6 months of age. And we were also excited here on the right, we're showing lung diffusion capacity. And again, those who received extra CPAP in the NICU had a significantly increased lung diffusion capacity at 6 months of age. And this analysis was based on multivariable mixed linear model to account for the correlation between the twin pairs and also to adjust for gestational age at birth, which was a stratification variable, and then sex and length at outpatient testing. We were also able to complete measurements of forced expiratory flows in 76 infants, with 38 from the discontinue arm and 38 in the extended arm. And you can see here again, the extended arm is shown by the green bars. So there was a significant increase, so improvement, so better flow at each of the levels. So for FEF 50, FEF 25, 75, and FEF 75, as well as the forced expiratory volume in 0.5 seconds in the infants who had received the extended treatment with CPAP in the NICU. We also administered a monthly standardized respiratory questionnaire to all of the infants through 12 months of age. And we had a very good completion rate, with the median number of RQs completed being 12 in each group. And as shown by the first row, 56.5% of the infants in the discontinue arm reported an occurrence of wheeze versus 44% in the extended arm. So this was not significant, likely due to our small sample size, but appeared to be going in the correct direction. There was significantly less healthcare provider diagnosis of wheezy bronchitis in the extended CPAP arm versus the discontinue CPAP arm. So in conclusion, stable preterm infants randomized to extended CPAP for 2 extra weeks versus discontinued CPAP to room air in the nursery have a significantly increased alveolar volume, lung diffusion capacity, and improved forced expiratory flows at about 6 months of age. Since preterm infants have impaired alveolarization and vascularization and impaired airway function, an increase in these parameters due to extended CPAP may take an infant from the red pulmonary function trajectory up to the blue and improve their lifelong lung function outcomes. So we have a number of sub-studies that we did within this randomized trial. And during the 2 weeks of randomization, we had a second pulse oximeter placed on the infant with its face covered, so the bedside nurses did not see the data, and the alarms were turned off. And this figure is a sub-study done by Dr. Mamadi, in which she analyzed oxygenation data from our last 30 patients, looking at episodes of intermittent hypoxemia to less than 90%, to look at these episodes in preterm infants around their NG or OG feeds, and also the effect of CPAP on these episodes during and after the OG feeds. So she found that preterm infants randomized to the extended CPAP spent significantly less time in hypoxia to less than 90% post feeds, and also had less episodes of intermittent hypoxemia to less than 90% compared to the infants in room air. She also found that there was no relation between OG feeds and the time spent in hypoxia or intermittent hypoxemic episodes in infants, in preterm infants on room air. So going against sometimes the common adage that CPAP can increase reflux and increase intermittent episodes of hypoxemia, she did not find that with this study. A few more just interesting facts and observations, and this is an X-ray from a study that we did at the Oregon National Primate Research Center, in which we were looking at the impact of CPAP on the lung development of preterm primate lungs, which we were able to also show that CPAP seemed to stimulate alveolarization. But as part of this study, we wanted to make sure that we were actually delivering CPAP to the infants. So we, here you can see this is a very translatable model. This is a PICC line. And we also placed an esophageal microtransducer intermittently in these little primates to monitor how much distending pressure was being given to the lung during CPAP versus how much was given to the lung, which we wanted to show that during the sham CPAP there was no CPAP being given. So this figure shows the stepwise changes that we demonstrated here in transpulmonary pressure as we increase our levels of CPAP, nasal CPAP given at the nose. So at the beginning we had 0 CPAP being delivered, but then as we increased to 3 centimeters of CPAP, the transpulmonary pressure increased, meaning that this pressure was being distributed to the lung. As we went up to 5 centimeters of CPAP at the nose, the transpulmonary pressure increased, and when we increased to 8 centimeters of CPAP, the transpulmonary pressure again increased, again showing that the CPAP was being distributed, increasing the transpulmonary pressure and helping to distend the lungs. Because in this study we were comparing CPAP versus sham CPAP in the premature primates, it was important for us to document that the sham CPAP was not distending the lungs. And this figure shows that documentation. So here in this figure, we have the CPAP in place, but we're not giving any CPAP. And during this this time period, we increased just high flow basically, starting at 0. Here's the transpulmonary pressure, and then we increased it up to 3 liters per minute. You can see no change in transpulmonary pressure, so no distension to the lungs. We increased it to 5 liters per minute, basically high flow, but no CPAP. Again, no change in transpulmonary pressure, and again, no change in pulmonary pressure when the flow was increased to 7 liters per minute. So again, demonstrating that high flow does not distribute distending pressure to the lungs, so does not mechanically distend the lungs in the same way that nasal CPAP does. With that, I wanted to acknowledge all the tremendous support that we got to complete this study, particularly the families who participated in the study in the nursery and all the tremendous NICU staff that supported the trial. These results are being presented really worldwide and have garnered a tremendous amount of interest from many neonatologists. And thank you so much for supporting the study. We're hoping to continue to follow these children so we can document the continued progression of their pulmonary function as well as their respiratory outcomes. And the results of this study are very exciting to potentially help improve the lifelong pulmonary function of preterm infants. Thank you very much.
Hi, my name is Jamie Wagner. I'm one of the neonatal nurse practitioners here at OHSU's NICU. I wanted to talk today about our CPAP protocol, specifically on how to apply CPAP with the Hudson prongs system, and also some troubleshooting tips if we have difficulty with establishing good bubbling, or if the baby has difficulties with increased work of breathing or increased FiO2 requirements. There's a few things you can do to optimize the CPAP before escalating PEEP or FiO2. And we'll start first with all the equipment, supplies that you need to get a baby ready for bubble CPAP. First and foremost, when you have a baby that needs to be put on CPAP, you're going to be working closely with your respiratory therapist. You're going to identify what size Hudson nasal CPAP kit you're going to need. Typically a size 0 is about for 700 grams or below, size 1 is about 1,000 grams or below, size 2, 2,000 grams and below, size 3, 300 grams, size 4, 400 grams. And so once you figure that out, you grab all your supplies. First, for a baby about this size, this is a micro preemie, we're gonna need to go ahead and get the size 0. The kits come like this now, packaging with the Hudson prongs, hat, and Velcro. You're also gonna need to get, for safety pins, 2 rubber bands, a size 0 cannulate. That's also back there is for the CPAP chin strap with the Velcro attached to this either side. The RTs will be helping out getting the tubing and then picking up, also helping out with the setup of the nasal prongs attached to it. We also need a red stopper. It's also good to have your suction supplies available, as well as saline fish. Once you have all the supplies, you want to make sure your baby is in the optimal position to receive the CPAP, and that includes adding a shoulder roll and then putting on a stocking hat with the Velcro at the top of the head. We try to avoid the back of the neck as much as possible, or the back of the head as much as possible, because that will cause the chin strap to fall down on the baby's neck and kind of compress the soft tissue here instead of being on the chin. So next step, after the tubing is all connected and the hat's in place, you gather your rubber bands and your safety pins, and you're going to do 2 safety pins on either side of the head, put the tubing through that, and then wrap the rubber bands around the safety pins to secure the tubing to the hat. And you want to be very careful about the positioning of the tubing against the side of the head. You'll notice that it's more on the side of the temple of the baby, or the zygomatic process. It's very important to keep it there versus straight up on either side, because this allows for more security of the CPAP setup. As the baby moves, it will move with the baby. It also allows for this nice curve of the bar to kind of align with the face, the curvature of the face and the upper lip. You want to make sure that the bar is away from the upper lip, has like space between it though. And you also want to make sure that this bar is away from the septum. There's a nice space between there. That's extremely important for preventing septal breakdown. As you remember in the previous part of my video, we attached the Velcro to the top of the head, and then this is where we move forward with attaching the chin strap as such. Kind of keeping that closed right there. You want to make sure it's off the soft structures, tissue of the neck, and just on the chin. And also, we are assuming that this baby will also be having a cannulate on as well to help with any air that might escape. Sometimes when your babies are on CPAP, they'll have an acute episode of increased work of breathing or increased FiO2 requirements. So you want to go in and make sure that the CPAP setup is on properly. Like for example, if you came in on this baby that was having increased work of breathing, maybe upset, looking air hungry, the first few things that you'll notice is that the neck roll is all bunched up in the wrong positioning on the shoulders. So you're going to want to adjust that. You also notice that this hat has come down over the eyes, and that can cause a lot of discomfort or just agitation from the baby. So making sure that's kind of pulled up away from the face. We're going to have to adjust this CPAP tubing more towards the side of the face, and then obviously bringing in the prongs up a little bit more. And if you do all this and the baby's still having difficulties work of breathing, the next step is to do some good suctioning. I know these nasal aspirators are used very frequently, but when a baby is having a difficult time and you can't explain it, you need to go ahead and use a suction catheter, and you need to do a deep suction down both nares. You apply just like 2 to 3 drops of the saline before you in the nares before you insert the suction catheter. Make sure you do both nares in the mouth, and eliminate that as a source of obstruction that's causing the baby to not receive the CPAP. I sure hope you found this video informative and helpful as you take care of babies on bubble CPAP. Thanks for listening in.